It's just about 12:30. We'll give it a couple minutes. You're at the knee pain workshop. If you're looking at the worksheet, it may say knee pain and arthritis workshop. It looks like I have one person in. If you could type your name in the chat and something about what makes your knee hurt or what brings you to watch this presentation, that would be helpful. Looks like Linda's the one that's in. Linda, if you've typed anything in the chat, I'm not able to see it, but no, that's fine. Just because you're the only person on, I'm still going to do it. This is actually the first time we've done the knee pain one online. We've done it a number of times in person, but if nothing else, it'll be good practice for me. We are streaming it live on Facebook, and it does get recorded. Nope, everybody's kept muted, and the only way you can communicate with me is through the chat box. I could unmute you, but don't really plan on unmuting anybody or turning their video on. All right, well, since it is a little after 12:30, Linda, I guess it's you and I. Hopefully somebody else will join on and we'll go through the workshop. Have you been a patient, or are you familiar with our office? If you could just type that in the chat box, that'll give me, or just let me know if you're familiar with the office. No, our office is actually located, we have an office in Colchester and we have an office in Hebron. That's where our two offices are. We've been around since one office opened in December of 1989 and the other office opened in January of 1990. To be honest, I opened the offices, and to be honest with you, it was so long ago, I can't remember which office opened first, but we've been around for roughly 30 years. It sounds like you're familiar with physical therapy. There is a different organization over in East Hampton. So why don't we get started? We'll go through this, and if anybody joins on as we go along, I'll should be able to notice that, and we'll take it from there. So if you have the worksheet that I emailed, you can follow along on the worksheet. Otherwise, the slides in and of themselves will make sense. All right, so we are at the knee pain workshop, and the point of the knee pain workshop, as well as all of our workshops, is to give people information that they can use to hopefully let them get back to the activities that they want to do using natural methods, so they don't have to take medications, get injections, or have surgery they don't need. The knee pain is probably our third most common condition we treat, behind neck and back pain, but it's followed closely with shoulder pain. Sometimes we see more shoulders, sometimes we see more knees. We do have workshops on neck pain, back pain, knee pain, shoulder pain, hip pain at this point, and it's hand pain and carpal tunnel as well. And the point of all our workshops is to give people information that we think they should have so that people don't end up getting treatment that they don't need. So my name is Chris DiPasquale. I am a physical therapist, and the other young lady on this slide is Katie Peterson, and she's also a physical therapist. I work mainly out of our Colchester office, and Katie works mainly out of our Hebron office. And the slide has the two of us on because we rotate back and forth in doing these workshops. Today it's my day, and I happen to be doing the knee pain and arthritis workshop. This Friday, Katie, I think, is doing the low back pain and sciatica workshop. We are two of the 8 physical therapists that work at our offices. Again, our offices are in Hebron and Colchester. We've been open throughout this COVID-19 crisis. We're generally open 7 to 7 Monday through Friday, and we're following all the public health guidelines and doing all sorts of extra cleaning and sanitizing. So this is the first question on the worksheet, and to try to keep me on track and to try to get the presentation over in about 30 to 45 minutes, we use a worksheet to kind of keep me moving along. So as we go along over the next group of slides, I hope to answer these questions for you. And you can either fill it in, or if you want, you can send me an email and I can send you a filled in worksheet. So we're going to start by defining what we're talking about with the knee joint. And basically the knee joint has 3 compartments. So the first blank, and I'm looking off to the side so I can look at a copy of the worksheet. In the first blank, you should put the number 3 between has and compartments. The first compartment is under your kneecap. And here, this is a kind of a diagram of your knee joint. This side is from the front, where the cursor or the pointer is moving around. I hope you can see it. I think that's better. Now you should be able to see the pointer. So this triangular bone right here is your kneecap, and there's kind of a joint surface right below it. It's basically on the front of your thigh bone or your femur. So that's one of the compartments. So the next blank, 1A, first where the kneecap, or you could write patella, sits on the front of the thigh bone. Then it says on the worksheet, then an inner compartment. So this is a picture of the knee joint from the back. This would be a right knee looking at it from the back. And the knee joint between your thigh bone and your lower leg bone actually has 2 compartments. One on the inside, so there's an inner compartment, where and then in the second blank, there's an outer compartment. So this is on the inside of your knee, and this is on the outside of your knee. So that should be pretty straightforward. So we're going to move on, and this is a picture of a Hinge knee brace, which we put on people's knees. So the answer to the next question, 1B, is it's a hinge joint. And again, that's a hinge knee joint, hinge knee brace. We classify, all joints are classified in as all different types. This is just getting everybody kind of up to speed on what kind of a joint the knee is. In a live workshop, I would draw a picture of this on the bulletin board and discuss it in a little bit more detail, but it's really not something we're able to do during an online workshop. All right, so the knee joint is stable because of the blank, and the answer is ligaments. So this is a side view of your knee joint, either looking from the inside or the outside. This part is your lower leg bone, and this would be the end of your thigh bone. This red line up and down here, I guess it's not a great picture since the cursor's red, but this red line is one of the ligaments. It's called the collateral ligament, and there's one on the outside of your knee, on the outer side of your knee, and one on the inner side of your knee. And then on this diagram over here, and I wasn't able to find good diagrams. I apologize that they look like they were drawn with crayon, but I ended up drawing these myself using a tracing program I discovered on my computer. So on this side, the crisscrossing green lines, those represent the cruciate ligaments. And I'm going to go back a slide for a couple slides. And the cruciate ligaments actually crisscross through the middle of your knee joint in between the 2 compartments. So we're going to jump ahead again. And it's the red ligament or the red ligaments or the collateral ligaments on the sides, and the green ligaments, the cruciate ligaments that are crisscrossing in the middle, that provide some stability to your knee. So the answer, the knee joint is stable because of the ligaments and cartilage called and the answer for that is meniscus. Now you might have noticed these blue triangles from the last picture. This would be the front of the knee, your kneecap would be over here, and this would be the back of the knee where your hamstring muscles are. This is looking from the side. And basically the meniscus is a wedge-shaped piece of cartilage that keeps the rounded end of your thigh bone from sliding forwards or backwards, also side to side, because the meniscus goes all the way around your knee. It takes a flat bone and it kind of creates a little bit of a cup for the end of your thigh to sit in. So that's another way that you end up with stability. And this is a picture of an airplane wheel with wheel chocks, which are essentially triangular shaped blocks that are in the way, and it stops the wheel from rolling. In your knee joint, the meniscus is a triangular shaped piece of cartilage, and it stops the rounded thigh bone from sliding off. That's where you get some of your knee stability from. And both the ligaments, which we had on the prior page, and the meniscus, which we show isolated on this page, are things that get injured or damaged as time goes on and can cause some of the problems in your knee. You may very well have heard of somebody that has a torn meniscus or a ligament issue. So if you have any questions, just type them in as we go along and I'll try to answer them for you. Otherwise, we'll get moving. All right, so now we're going to move on to 1D, or to question 1, letter D. And we're going to talk about the things that need to work together or work normally in order for you to have a pain-free knee joint. So the joints next to the knee, including your low back, your pelvis, and it's not actually your pelvis isn't a joint, but in the middle of your pelvis on the back is the sacrum. It's kind of covered by ligaments in this picture here. And then on each side, you have bones that are called ilia. And where the sacrum and the ilia come together, you have a sacroiliac joint. We sometimes call that the SI joint, the hip joint, and the ankle joint. So if you just write low back, pelvis, hip, and ankle in the first 4 blanks under D number 1, those are all the answers. And all of these joints, if they're moving normally, add a little bit of springiness to our skeleton so that we can absorb forces each time we hit the ground. So if you have a problem in your back, or your back in your pelvis, or your back in your hip, or your hip in your pelvis, or any combination, you lose some of the springiness of the system, and you can end up with having force concentrated in the knee joint. A knee joint is a place where your body might try to compensate for a problem, and then you end up with pain. So one of the ways we address that is, although you come in for a knee problem, we need to make sure all the other areas are working correctly and don't have an issue. And if we do identify an issue, we have to work on the issues in those other joints. It's also important that your low back is working normally, because the nerves that control the muscles that support your knee joint can get pinched if you have a back problem, and a pinched nerve can shut the muscles down, which can cause force to be concentrated at your knee joint. So we need to make sure that your back is working as good as it can. If you do have the same thing with your sacroiliac joint or your pelvis, the nerves travel from your low back right across the front or right next to your sacrum, and they're all buried in muscles. So if you have a problem with your sacroiliac joint, the muscles go into spasm. They can impair nerve flow, which can cause muscle weakness, or just pain, which can make you move abnormally and concentrate force on your knee joint. So that's why we would have to make sure that's working correctly. And the hip and the ankle, in a similar way, if they're not moving correctly, you can end up with force concentrated in any of the 2 compartments on the bottom of your knee joint, or even in the front of your knee joint. And we don't really need to talk about the ankle. It's the same problem for all the joints. All right. So I've already talked about question 1D, number 2. So the other area, so the first area was really joints. The second area, so number 2 under D, is muscles that control the joints around the knee. If your muscles are weak, you end up with excess force concentrated on the knee joint, which is going to cause the knee to break down and is going to cause pain or problems. So we need to minimally, and everybody should make sure if they have knee problems that they're doing the appropriate exercises to make sure that it's just not an issue of simple muscle strengthening. All right. And then the number three is D number three is mobility or flexibility to allow the knee and joints around it to move freely. So we need to make sure that you have adequate flexibility in the joint capsule, the tissue that makes the joint a closed container, as well as the muscles around the knee joint. For example, your hamstring muscles in the back, your thigh muscles in the front. It's hard to really point that out, but going across the front of your hip flexor muscles, if any of those muscles are not flexible or if those joints are not flexible, that has to be addressed. Otherwise, you end up with force concentrated on your knee. All right, so we're going to wrap up question number one. And I think I'm doing okay for time. I'm about 15 minutes into it. I'm just going to check and make sure. There's nothing else in the chat, and you're still here, so that's good. So the next thing we're going to talk about is 1D, arthritis and what arthritis is. Because everything I talk about applies to people that have arthritis that's causing their knee pain. And it also, you can have knee pain that's caused by other things that's not arthritis. But in general, we just want people to know that the word arthritis is made up of arthro, which means joint, itis, which means inflammation. So arthritis simply means joint inflammation. It's really not the end of the world, and it's just a normal part of life. As time goes on, we all get arthritis. All right, so this is, we've established kind of what the knee joint is and what needs to work properly in order for you to have a healthy knee joint. Now I want to talk about how it is that we've come to specialize in knee pain and not only knee pain, the other joints in your body that good conservative care does just as good as treatment with medications, injections, and surgery that come with side effects and costs that most people can avoid. So back in 2003 is when some of the first studies came out. If you're a reader of the Wall Street Journal, in 2003, they published an article saying that fake knee surgery, people that had fake surgery did just as good as people that had real surgery. And the way these studies are done, the one I'm most familiar with was done over in Europe. And essentially, they took 200 people. They told them they were all in the study. So the study's done like this. You take 100 people, and you actually put the scope in and you do the surgery. You trim things up or you fix whatever the degenerative problem is. The other 100 people, they just put the scope in, they take a look around, but they didn't do any surgery. And then everybody went to physical therapy after either the sham or the fake surgery and the real surgery. And there was no difference between groups 6 months later. Now, I'm not trying to suggest that anybody's trying to trick people into having surgery. I don't think orthopedic surgeons do that. I think that they're trained to treat people with surgery. And of course, I think I can fix the world with physical therapy. But the bottom line is there have been real studies where that are done very well, where they compare, in essence, fake surgery to real surgery, and there's really no difference between groups. Now, they've also repeated the surgery on other joints as well as the knee joint, and the differences hold up over time. There was some early suggestion that, well, maybe it's because you didn't give them enough time to see if the groups were the same. And it turns out that 6 months, a year, and 2 years later, groups that have real surgery versus group that have fake surgery for degenerative changes do about the same. The second point I have up here is that there have been a couple really interesting arthritis studies where they looked at people that were going to have total joint replacements. And in one study, it was done with a population of people in the Army, where what foods cause inflammation, and also what causes my knee to click when I stand up. All right. There are definitely there are inflammatory and anti-inflammatory foods. That's not something I'm prepared to get into as part of this talk. We do support nutritional interventions and think that they're a very important part of what people can do to take care of themselves, and do recommend that people do try to follow anti-inflammatory diets, because I think they can be helpful. Many of us use a variety of dietary interventions personally. I know that I'm a big proponent of low carb diets, because I believe that there's a fair amount of evidence that high carb diets, there's not a benefit, there may be a risk, and one of the risks may be inflammation. And probably clicking when you stand up can be caused by a number of things. It can either be your kneecap shifting, it can be deterioration of the meniscus or the cartilage that we talked about, or it could be just general arthritis in your knee. We'd have to look at your knee before we could give you more definitive information, but I hope that helps. So going back to the 40 to 70% of people that got PT ended up not getting joint replacements. In one study, they sent a bunch of people that were covered by a military hospital to PT before they were going to have their joint replacements. And in one study, about 70% of the people elected to not go on and have their knee joint replacement. Those people had hands-on therapy to work on and to get their low back, their hip, their knee, and their ankle moving, as well as specific exercises to address any strength impairments and flexibility impairments that they found. So that's a pretty powerful study. And another study that was a bit more limited and done over in Europe, they looked at people that were going to have total hip replacement surgery. And it turns out that just giving people specific exercises to address their strength deficits, 40% of those people that were scheduled to go on and have hip replacement surgery elected to not have the hip replacement surgery. And then the last reason we talk about in terms of our specializing in these conditions is that since we opened in 1989, we've done over 250,000 treatments, and knee pain is one of the top 5 things that we see. It's neck and back pain, shoulder pain, knee pain, and then it's probably the next couple are hip, hand pain, hand and elbow pain, and then foot and ankle pain. So we, even if you live in East Hampton, Linda, we like to talk about there being about 10,000 people living in Hebron, 15,000 people or so currently live in Colchester. So if we've done 250,000 treatments, we like to say that although we're not McDonald's, we've treated everybody in Hebron and Colchester at least 10 times. All right, so for question 2, you can 2A, it's up to, you can write 40 to 70% of people may not need surgery. Those were arthritis studies I talked about. We're going to come at it from a different angle when we talk about MRIs in a minute. So we're going to go to 2B, maybe. All right. So on the left side of the screen over here, this is an X-ray of a knee, and on the right side, that's an MRI of the knee. So the other thing that you should know is they've done a boatload of studies looking at X-rays of normal people. So if you take an X-ray, which you're seeing on this side, or if you do an MRI of 150-year-olds that don't have any knee pain, there's going to be a substantial amount of arthritis or a substantial amount of other degenerative changes, kind of the meniscus, and you can sort of see the meniscus right here, that triangular thing, on up to 50% of these normal people that don't have knee pain. So we recommend that people don't end up going someplace where they're going to get an X-ray or an MRI, and a result of that X-ray or MRI they're going to end up going to have surgery that they don't need. So we feel that that's one of the reasons we've gotten to doing these workshops, and we've started to present this information. All right, so now we're moving on to 2C. And 2C is people that had, and the answer is surgery, that still had pain and they were limited. And it's basically, we've seen people that have come into the office, they've had knee surgery and their knee still hurts. We could say the same thing about shoulder surgery and their shoulder still hurts, back surgery and their back still hurts. It's interesting with the back, a lot of times, if we treat the sacroiliac joint, their back pain goes away even though they had back surgery for it. For the knee joint, a lot of times, or in the cases, not a lot of times, in the cases where people come in, they've had surgery and their pain doesn't go away. When we treat and clear the other areas like the back, the hip, and the ankle, a lot of times in this particular case, the knee pain would go away. All right, so moving on to question 3. The first step is your pain and we want to know if it's reproducible. So these are just a couple pictures of things people tell us causes their knee to hurt. So one of the most common ones is walking upstairs. And or it may be sitting. Sitting might make your knee hurt. Or it may be going from sit to stand that makes people's knee hurt. Typically walking upstairs, if people complain of knee pain, walking upstairs, usually downstairs hurts more because it causes you to generate more force on your knee because of your muscles. But typically it's often a kneecap problem. Sitting is interesting because often people that sit and end up with pain that's coming from the sacroiliac joint, depending on how old they are. Or it can also indicate a kneecap problem because when your knee is bent, your kneecap or your patella is being forced into your knee joint. People that complain of pain when they first get up in the morning, that gets better as the day goes on, that's often more arthritis pain. So we want to know what reproduces your pain. And if you're thinking of having something done about your knee, that's something to pay attention to. What makes your pain worse? Because if your pain's reproducible, there's probably a mechanical component to it that we can address. We like to say it's reducible. So if you take pro out of reproducible, you end up with reducible. And paying attention to those things allows us to kind of zero in on all of the causes of your problem. All right, so we're moving on to question 4. The single biggest mistake that you can make with any problem is you can ignore it. And ignoring it usually sounds like an excuse. My knee hurts because I'm 59 years old. I have arthritis. So when I do too much, my knee hurts. That's an excuse. Or my knee hurts because my dad's knees hurt and he has arthritis, so I just inherited it. So the problem with ignoring it is that it won't go away, and whatever's causing it is likely to get worse over time. When it first starts, or even kind of in the middle of the journey of deterioration, we can do a lot more about it. But if you let things progress, it's harder and it takes longer to get it all the way better. And you may end up having to have something done that we could have prevented with natural treatments if you don't take care of it now. So the next option is, and the answer for, as you saw, was you can alter it or mask the pain. And this generally involves pain pills or injections. And the problem with pain pills, Tylenol doesn't have the problem I'm going to talk about, although Tylenol certainly isn't something that should be taken for a long period of time because it also has serious side effects. But the most common pills people take are things like Advil or Aleve. They're anti-inflammatory pills. You knock out the inflammation and the pain, but you don't cure the cause. And I know that you're thinking, well, the inflammation is from the arthritis, and that may be true, but you got to keep in mind that if you take 150-year-olds and you do an X-ray of their knee or an MRI of their knee, 50% without pain, who never have pain, have arthritis. So the arthritis might be a component of it, but the problem may be related to your back, your hip, your muscle strength, your ankle. And if we can get everything else working optimally, you won't have the pain and you can go on with your life without limitation. The problem with taking the medication is you're just temporarily getting rid of the inflammation, you get rid of the pain, you go back to your activities, but the underlying problem still exists. And then the other issue is that out of every 1,000 people that takes these types of medication, Advil or Aleve or even prescription medication, on a chronic basis, 3 of them die every year from side effects that are typically related to kind of bleeding ulcers in their stomach. The other thing that a lot of people get are cortisone injections. And the problem with, it looks like somebody else joined us. Hi, Cheryl. And the problem with cortisone injections is the same as with taking the Aleve or the Advil. The cortisone blocks the inflammation and it blocks the pain, but you never end up taking care of the underlying problem that's relatively easy to take care of and doesn't come with the same risks and side effects as medications, injections, and surgery. So that's enough said about that. I just want to check how we're doing for time. And I'm going to try to wrap this up in about in the next 10 minutes. Let's try to move on to the next slide. So the third thing you can do is you can handle your problem. And people at this workshop, it's either for themselves or their friends with pain, is you can handle it. So I walk the dog on the golf course. I happen to live near Blackledge golf course in Hebron, and at night I walk the dog out there. So this is a sand trap, and this is the green. We want you to handle it, but we want you to be careful about how you handle it. And that goes back to the MRI or the whole X-ray story. Because the typical story is your knee hurts, you go to a primary care doctor, they try medications, the pain keeps coming back. You get either referred for an X-ray or an MRI, or sometimes they refer you to the orthopedic surgeon who wants you to have the X-ray or an MRI. The X-ray or the MRI shows deterioration. You might need a trim up, or some other procedure is recommended. It makes perfect sense. If you hadn't been to this workshop, you'd probably go ahead and have the surgery, and you will have fallen into a trap. Now, again, I don't want you to think the orthopedic surgeons are trying to trap you or trick you into having surgery that you don't need. They're trained to do that. We're just telling you that a lot of the studies indicate that you should at least try physical therapy. The other thing I want you to be careful of is the trap of going to an orthopedic surgeon who says, well, I'd like you to have an MRI so I can see what's going on. But the problem is your insurance company won't pay for it until you go fail physical therapy. So what do you think is going to happen? You're going to go to physical therapy. You're not going to be happy about it. You're going to be mad at your insurance company. You're going to go, you've kind of pre-framed yourself or set yourself up for not getting better. After 8 or 10 or 12 visits of therapy, where you go, and unfortunately a lot of therapy offices, you won't get any hands-on treatment. You'll just ride the exercise bike and do some simple exercises. You will fail physical therapy because you won't have your back worked on, your hip worked on, your ankle worked on, everything looked at and all the causes addressed. Then you end up going back to the surgeon, you get the MRI, it's likely to have, or an X-ray, and you're likely to see things on it that it's going to make sense that you're going to need to have treatment done. And then you go to have surgery. Again, that all could have been avoided, even the cost and the time associated with the MRI, as well as the cost, time, and risk of surgery and medication. You know, the bottom line is one MRI costs about the same as 12 visits of physical therapy. And it takes an average of 12 good visits of physical therapy for people to get better. That's a national average based on people that go to physical therapy. All right. So the three common causes of knee pain. We're in the home stretch. I'll just give you the answer. A is limited mobility. And again, we're talking about things like joint mobility, like your hip moving, like the joints in your low back moving in between the vertebra and your spine. Your knee joint moving. A lot of times in the three compartments in your knee joint, the tissue around your kneecap might be tight, restricting the way your kneecap moves. And there may be problems at your foot and ankle that need to be addressed. So if we address all of the mobility, that is one of the ways that, and this is a picture of a shock absorber and a spring on like an ATV. So all the common causes of knee pain are a lack of mobility, a lack of strength, or a lack of flexibility. So if we improve the mobility, you end up with good kind of springs and shock absorbers just by the way the joints are all able to move and work together. If we increase the strength, we allow your muscles to absorb force. The muscles are acting like a shock absorber and a spring. And the same thing with flexibility. If your joints move, but your muscles and your tendons have gotten too tight, your whole, what we call your lower quarter, the whole combination of your back to your hip to your knee to your ankle isn't able to absorb forces, and the forces can get concentrated in your knee joint, and the end result is that you end up with pain. All right, so we're going to move on to question 6, and I appreciate that you guys have hung in there. Both Linda and Cheryl joined us along the way. Whoops. So, sorry about that. Whoops. There we go. I'm going to stay on the slide and stop pressing buttons. So the picture on the top left is hands-on treatment of the knee joint. That's either joint mobilization or manipulation of the knee joint. And it's something we do for your low back, your hip, your knee, your ankle, and your foot, because we need to make sure that the joints are all moving properly and nothing's restricted, so that force is getting concentrated on your knee joint. So that's what a picture of this is. So what does successful treatment of knee pain and arthritis look like? A, it's hands-on PT to move the knee joint compartments and surrounding joints. So B, this is strengthening. This is a strengthening exercise. It should be strengthening and flexibility exercises should go in the second blank. This is just a slide of me doing straight leg raises. That's a common exercise that we do in the office for people with knee pain. And if you happen to have knee pain, it's one that we would recommend seeing. If you're interested in just seeing general exercises, if you go to our website, which is pptsm.com, you click on the YouTube button in the top right off of the homepage. I will take you to our YouTube page where there are a bunch of knee and leg exercises that we encourage people to try out. So Cheryl, I see you raised your hand. If you want to type something in the chat box, that would be good. So I don't see anything in the chat box. Or you could type in the question and answer box if you could find that. So if you have a question that you'd like me to answer, Cheryl, you can email it to me and I'll get back to you, or I can give you a call if you prefer. But I'm going to kind of carry on. So, so 6B, we're strengthening and flexibility exercises. And again, that's to make sure that the whole spring shock absorber system of your lower body is working so that you don't have force concentrated at one of your joints. And in this particular case, your knee joint. This bottom picture is of, sometimes this is called KT tape, sometimes it's kinesio tape. It's something that we use from time to time on people in the office as kind of a temporary solution. to get you moving normally, hopefully not as a permanent way to allow you to move normally. We can help line things up or provide more feedback to your muscles and joints to get you moving in a more normal way so that your knee pain goes away. So one of the other things we do in the office, now we're on 6C, is dry needling. This is a dry needling. We essentially use acupuncture needles, and we use the needles to address what are called trigger points, which are areas of localized hypersensitivity that develop within muscles. And again, your knee can be impacted by a problem that starts in your back, in your hip, your thigh, or even in your leg. And depending on what the cause of your problem is, we do dry needling as part of a PT treatment. It's never the sole thing we do in a PT treatment. It's usually a small part of what we're doing as part of your overall treatment. And I know that this is a shoulder. I couldn't find a good picture when I was doing the slides for this presentation, but this is a class 4 laser treatment. Class 4 laser is relatively new in the clinic. We're one of the only therapy offices in this area of Connecticut that uses a class 4 laser. Class 3 lasers have been around for a long time, and they're pretty common in physical therapy, but we can get the light energy into the tissue to help things heal and to help knock out pain in 5 minutes that it would take about 8 hours to get that type of treatment in with a class 3 laser. Class 3 lasers are used in all like Division I college sports teams, as well as all professional athletic teams use them. So that's something else that we also use, not as our sole treatment, but as an add-on, often with dry needling, to the hands-on treatment, the stretching exercises, the flexibility exercises to address all the problems in your back, hip, knee, and ankle so that you can get rid of your knee pain and get on with life. All right, so I have come pretty much to the end of the presentation. So for people that have registered for the workshop and come on to the webinar, we offer a free discovery visit. Now, this address should be on the bottom of the worksheet that you guys all had emailed to you. It's performanceptworkshops.com. If you just put your first name, last name, email, and phone number, I know we already have it. But if you put this information in, and I didn't get a picture of it on the slide, but down below there's a register button. So if you fill in the form here and click register, we'll get a message that you've registered. Somebody will give you a call from the office, and we do what's essentially a free screening visit or a discovery visit. You come to the office, we take a look at everything, we explain to you what is wrong and causing your pain, what needs to be fixed, and we'll go over what we think your plan of care should look like. And then you can decide if that's something you'd like to do. So again, for being on the call and for register for the workshop, if you go to this website, fill out the form and hit enter, we'll give you a call and get you scheduled. That can be either in the Colchester office or the Hebron office. In the Hebron office, the 3 therapists there are Katie, Christine, and Zuzana. And in the Colchester office, right now it's myself, Jim, and Becky. So you'll see one of the 3 of us. We have 2 therapists that have elected to not work during the kind of COVID crisis. But our offices are open 7 to 7, at least 7 to 7, Monday through Friday. All right, so if anybody has any questions, I see there's a question. All right, I got the question. It's from Cheryl. I have bone on both of my knees. So I often, but forgot to talk about that during when I was talking about the x-rays. If you take, again, I don't know how old you are, and I'm not asking how old you are, but if starting at 50 and increasing age by decade of life, if you take 100 normal people At 50 years old, maybe 10% of the people are going to have bone-on-bone arthritis. And what I mean by 100 normal people is these are people without knee pain. 10% are going to be bone on bone. When you get to 60, maybe it's 20% of the people. When you get to 70, maybe it's 30% of the people. We recommend, and we think that the evidence is there, that you should try therapy before you go to surgery. Because if you took x-rays of normal people, that is people that don't have any knee pain or limitations in their life, and you looked at them, 10, 20, 30, 40% of the people, depending on the group that you look at, are going to have bone-on-bone arthritis. And I'm not saying that bone-on-bone arthritis is a good thing. It makes it more challenging. But often, if we can fix all the other areas, you'll do a lot better. I'm not sure if you were on when I talked about the studies about people that have had that were scheduled to go on for joint replacements. There are studies where people that were going to have joint replacements done went to physical therapy, and in the knee study, one of the knee studies, up to 70% of the people elected to not have the knee replacement surgery because of the hands-on treatment of their whole lower quarter, their back, their hip, their knee, and their ankle, as well as the specific exercises they were given for that. So I also see done that one for therapy has helped, but they're saying surgery. Yeah, I'm not 100% sure, what that means, nor am I sure where you've gone to therapy, but I would recommend you come in for a free screening. For one of the discovery visits, you meet with us. I can tell you that I'm not saying that what you did was wrong or what the therapist did was wrong, but I'd want to make sure that you had all of therapy you were supposed to have, or should have had, or could have had, that could have taken care of all of the areas that were contributing to the problem. All right, so I hope that helps. I appreciate everybody being on the call. And again, I would, everybody should go to performanceptworkshops.com, fill out the form, click the register button on the bottom, and we'll give you a call and get you set up for your complimentary free screening visit. I really appreciate everybody. Well, I see Cheryl's asked another call. What about weight? I mean, weight doesn't help, but weight doesn't cause bone-on-bone problems. It can be a contributing factor, but in and of itself, shouldn't stop somebody from trying therapy, and doesn't necessarily prevent people from getting better. Having said that, I'm going to wrap up our workshop for today, and I hope to hear from you all soon. Whoops.